Thank you very much for your kind introduction. My name is Max Lahaye. I'm an abdominal radiologist in the Netherlands Cancer Institute, and I would really like to tell you something about staging ovarian cancer with MRI and how we can use this imaging technique to predict whether a complete cytoreduction can be achieved. So let's go to the first slide. What I'm going to tell you about is a little bit about the background, a little bit about the MRI technique, because I don't think everybody is really acquainted with it, and we'll tell you something about how to stage peritoneal metastasis. I will show you some preliminary results and some cases, just to get you acquainted with this type of imaging, because in the next couple of years, MRI will be used more and more to stage ovarian cancer. I work in the Netherlands Cancer Institute, and it's also called the Antonie van Leeuwenhoek Hospital. He was a very famous Dutch scientist who made really good lenses, so he could make a very good microscope. And when he looked through the microscope, a whole new world opened for him, and he made some really interesting discoveries. Well, some centuries later, we're now really not only looking for cells, but we're looking at really atoms with MRI, and especially with new techniques like diffusion weighted imaging. We really are now using the full power of MRI. And what are those new techniques? What is diffusion weighted imaging? Well, diffusion weighted imaging, it tells you something about the movement of water molecules. So in tissue where water molecules can really move around freely, that area on the image will come black. Well, are there tissues with really restricted diffusion? That means that the water molecules cannot move freely around. Then this is in the case of tumor, then the area of that image will become white. So why is that interesting? Well, maybe you know these kind of pictures. It's like finding Wall-E. Well, MRI images are sometimes exactly like that. You have a lot of information on the screen, but you really only want to know where the tumor is. So that makes it sometimes really hard to find Wall-E or to find the tumor. But if everything will become black, what's normal, and tumor will light up, well, then it's going to be quite easy to see Wall-E or to see the tumor. So that's how we're using diffusion weighted imaging. And I will show you several examples of this later in my talk. Just briefly something about a protocol. Simple parameters and sequences which are already used every day in your hospital. So it's like a T2, a T1 with and without contrast, diffusion weighted imaging. And the only strange thing about this protocol is that the patients are required to drink 1 liter of pineapple juice 1 hour before the scan. Why is that? Well, in the pineapple juice, it's unaltered, you can just buy it at the supermarket. There's a lot of manganese. Manganese is a metal, and this really suppresses this high signal in the bowels, because I don't want the bowels to light up. I just only want to see the tumor. The whole scan time takes 35 minutes, so that's also really doable. I give you a brief example. This is some mental cake, clearly visible on CT in the red circle. And if you look at diffusion weighted imaging, so an MRI, then you really can see that everything will turn black, but the tumor will light up, and this is clearly depicted. So it can easily be seen that it's not bowel, it's tumor. What you also can see is that some ascites in the paracolic gutter on the right side also lights up. That's quite strange, because the water should be black. So there's also something going on, this malignant ascites in this patient. So that's also what you cannot say anything about the ascites on CT, But with MRI, it can really help you to see whether this is malignant ascites in some cases. So that's really interesting. But why are we want to predict whether a complete debulking is feasible? Well, if you look at the outcome of ovarian cancer patients, one of the most important prognostic factor is whether a complete cytoreductive surgery can be achieved. So not suboptimal, no, really a complete cytoreductive surgery is needed for an optimal survival for the patient. Of course, the location and the amount of disease is very important to see whether a patient can have a complete cytoreductive surgery, but also the clinical performance and especially also the experience and expertise of the operating physician is very important. It can vary between hospitals. Well, what the surgeons did, and especially this is well adapted in the colorectal Cancer Society, is that they use the peritoneal cancer index to see how much disease is in the abdomen. This is a surgical scoring system. This means that during surgery, the surgeon will look at all the regions in the bowel and in the abdomen and score accordingly. So how does this work? Well, they look into the abdominal cavity, they divide the abdominal cavity into 13 regions. In these 13 regions, each region will get one score. They will get a score of 0 when there is no tumor seen in this region. They get a score of 1 when there is the biggest tumor in that region is less than 5 millimeters. They will get a score of 2 when the biggest lesion in that region is between 5 millimeters and 5 centimeters. And they will get a maximum score of 3 when the lesion is bigger than 5 centimeters or there is confluent disease. And this works really well. It's internationally widely accepted in colorectal cancer, and almost every hospital treating peritoneal metastasis of colorectal cancer is using this scoring system, and it's also now getting more and more used in ovarian cancer. And if you look at staging and you want to stage the peritoneal metastasis, you don't want to do that with surgery. Preferable, you want a non-invasive technique to see whether a patient can be operated. You don't want to operate a patient to see whether he can be operated. So, and there we have some problems because the CT, what we now commonly use, really underestimates the peritoneal disease. It means that if you have lesions smaller than 5 millimeters on CT, the sensitivity of CT is only 11%. So you grossly underestimate the disease on CT. This means that when some patients are opened up to be operated on, sometimes the surgeon will see that there's too much disease and have to close the patient. This is something you really want to avoid. What about PET or PET-CT? Well, the problem with that is almost the same because it needs like 7 to 10 millimeters of cubic millimeters to be disease to be depicted. So that's also does not depict small volume disease. And that's why we're now looking for diffusion weighted imaging, because we know in other cancers it can really depict small deposits. So that will be very interesting to see. And that's why we started some research and some studies to see whether we could evaluate the diagnostic potential of diffusion weighted imaging to predict PCI, and whether MRI could also predict a complete resection in ovarian cancer patients. What we did, we started a prospective study of 25 patients, and these patients were all scheduled for surgery. They all got an MRI before surgery, and this MRI was read by 2 independent readers, and they scored the PCI and whether they thought that a complete cytoreductive surgery was feasible. And afterwards, the patient was operated. So the PCI could be measured by the surgeon, and also we could see whether a complete site reduction was feasible. So that was the reference standard. In this patient cohort, 8 patients did have an incomplete surgery. And what we saw is that we had a really good intra-class correlation between the PCI, what the radiologist thought it would be, and the actual PCI, what the operating physician scored. This means that MRI really is accurate in predicting the PCI. And we also saw this in other studies and also with other studies in other cancers, that MRI could really accurately predict the PCI. Interesting, both readers had also a very good interclass correlation, so it's quite a robust scoring system using MRI. Interestingly, we also could really predict whether a complete site reduction was feasible. We even were slightly better than the operating physician to see whether a complete site reduction was feasible, but that was of course not significant. So is this the holy grail, this MRI technique? Well, I think in the end, the role of MRI will not only say, okay, this patient can be operated on, and the other, no, we have to wait, you have to give more neoadjuvant treatment. But I think there will be also a third category where we can say, but okay, MRI is not sure. What we saw in colorectal cancer, that we are quite sure with MRI in 80% of cases, and in 20% we would like to have a laparoscopy or some kind of surgical exploring to see whether the patient is operable. So let's go to some cases, because I think it's really important for physicians to really get acquainted to MRI imaging, because we will use it more and more in oncology imaging, and especially in ovarian cancer. Let's start with a simple case first. So this is a patient, this is a coronal view on the left, and you can see the actual slices on the right. And you can really see that this patient has really a mental cake. It's clearly visible, but to be honest, these kind of cases can also be seen on CT. So this is not where MRI will have a lot of added value. However, if you look like other cases, like this one, in this case, the lesion is very really snug into the bowel wall, and then it's easily missed on CT. To be frank, we missed this on CT, our radiologist in our hospital, but later on we performed the MRI and it was clearly visible. Here also can see the benefit of diffusion weighted imaging, where the tumor really lights up, and that draws your eye to it as a radiologist. So that's very important. Also smaller things like some induration on CT. As a radiologist, is this induration, is this fluid, is this tumor? We don't know. On T2 weighted images, it looks almost the same as CT. And again, it's also for us really hard to say what it is. But if you look at diffusion, you can really see it really lights up. So something is really wrong there. And this was all these cases are histology proven tumors. But even smaller lesions like those, which you can see on diffusion. So you're looking at like 2-3 millimeter size of lesions can be depicted with MRI. And these lesions was not even mentioned on CT, of course. Another case is a very interesting case where this is the MRI. Maybe you can miss the lesion here on MRI, but if you use diffusion, it really lights up like a light bulb, and that's very important. In this case, the surgeon could not find the lesion in the left lower abdomen, and he called me during surgery like, Max, I cannot find it, you're wrong. I said, well, I'm not wrong, I can clearly see it on the diffusion weighted imaging. So I went to the operating theater and pointed it out for him where he had to look, and they found it. And otherwise this patient would be closed and the tumor would remain in the patient, so it didn't help the patient. at all with that surgery. So that's why it's important to really use advanced imaging techniques to stage the tumor, because also during surgery, sometimes lesions can be missed. Another example, in the paracolic cutter on the left side, you can clearly see a small white dot on the diffusion weighted imaging on the left, and this was indeed a small tumor deposit. On CT, those small lesions, you cannot see them, and that's why I already mentioned the low sensitivity of small volume peritoneal metastasis on CT. Even if you know it's there, you won't see it. As I mentioned sometimes in this talk, I think ovarian cancer will be imaged with MRI more and more. And we're now conducting a multi-center study in the Netherlands with more than 270 patients to see whether MRI has that diagnostic accuracy as mentioned in the pilot study. And if so, the guidelines will change and to also include MRI in advanced cases to help physician to make a better treatment decision during the MDT on which treatment the patient will benefit the most. And with that, I would like to conclude my talk and thank you for your attention.